I think that's not a reason to avoid talking about it. I think it's a reason to talk about it. Your loved one is holding something heavy in their heart. And so you can really show up and support them by addressing this or talking about it or providing a safe space for them to discuss, what they're hoping for, what they're worried about, what they're picturing.
So this morning, I'm on my way to work and I saw a baby deer. I guess you call it a fawn, walking down the middle of the road. So the unusual thing is that I look to the right and to the left and there's no mama and there's no other deer. So this fawn is by herself walking down the middle of the road. And I'm thinking, have you ever found yourself somewhere you didn't want to be? Maybe you went to the hospital or a doctor's office because you didn't feel well, and suddenly somebody's talking to you about hospice. And just like that little baby deer, that fawn, you just want to get out of that road. You want to get over to the green grass with people you love. I'm your host today, Steph Cain, president of Our Hospice, where we provide hospice care, palliative care, and personal care. And in our last episode, we ended by inviting you back for more meaningful conversations. And today, we're with our medical director, Dr. Leigh Anderson. Let's talk about one of the hardest but the most important parts of hospice. Where do you begin when starting that crucial conversation?
Yeah, and I'll kind of phrase this as if I'm a family member too, because I know a lot of you might be tuning in to listen to or to get ideas on how to broach this subject with your loved one. For me, the best place to start is making sure that everyone's on the same page. So, in medical phrasing, we call it assessing understanding. And so this might look like, you're chatting with your sibling in California, who lives in California. You're here close to mom, and you check in with your sibling of, hey, where do you think mom's at with her dementia? Or how do you think things are going with mom? And maybe, your sibling in California who sees mom a couple times a year maybe says, well, I think she's doing fine. She's maybe gets a little confused from time to time, but is getting around okay. And, I think we're doing great, And you as a sibling that maybe sees mom a little bit more, have an opportunity then to kind of mention, well, mom's starting to get a little bit more forgetful. She's been microwaving a couple of things here and there. She's fallen, over the last, whatever the situation is.
Mm-hmm.
So it kind of helps to bring the decision makers together and just make sure everyone's on the same page. Another example, you're chatting with dad. Maybe dad does have a good understanding of where his disease is. Like, well, my heart failure has gotten pretty bad. I'm going to the hospital quite a bit. And, they try to get that fluid off, but there's not too much more they can do to make my heart failure better. So then you kind of know, okay, dad knows what's going on, here. So once you've kind of gotten people maybe close to the same page, or you kind of have an understanding at least of where people are, then it makes it easier to kind of take that next step. I think the next step is what their goals are. I think that's kind of the most important. And then the best way to talk about goals with a loved one is, hopes and worries. Hopes and worries, hopes and worries.
Mm-hmm.
So if you can talk to dad, and maybe dad, let's say dad's in denial. Oh, I'm doing fine. I go to the hospital, they tune me up, I come home, no big deal. And you kind of are like, side-eyeing, like, what do you mean? You've been going to the hospital once a month, Dad. It really is hard on you to go to the hospital as frequently. You can ask things and hypotheticals too, and you can still kind of get at what Dad's goals are. And so this would sound like, hey, Dad, if time were short, what would you want life to look like? Hey, Dad, if time were short, what would worry you, or what would you be worried about?
Mm-hmm.
What are you hoping for if you had, a short amount of time left, kind of a thing. And you'll get a lot of really good responses to that question.
Mm-hmm.
Maybe it's, well, I really want to be home.
Right.
I'm tired of going to the hospital. I really want to be home. Maybe it's, I love my dog. I do not want to be separated from my dog. Do not take my dog away.
Mm-hmm.
Maybe it's, I want to be alive. I want to be around to meet my granddaughter that's going to, whose due date is like 2 months from now or whatever it is.
Yeah.
So as a family member, as you hear the answers to those questions, hold on to those and remember those and move towards those. Do what you can to kind of make those goals happen. And sometimes, you hear something that you're like, that's not possible. Maybe dad's goal is to stay at home and your mom is there and her health is failing and she's not going to be able to take care of dad.
No.
While as dad gets older and older or as the disease progresses and he gets weaker and weaker. So then, you can also take that time to maybe mention, you can ask permission too, but hey, Dad, is it okay if I tell you, something that I'm worried about if time were short, knowing that your goal is to stay at home? Yeah, sure. I'd love to hear what you have to say, and then you can say something like, well, I worry Mom isn't going to be able to take care of you safely.
Right.
As your disease progresses or as you get weaker. Mm-hmm. And you don't have to feel, you can just say that and leave it. Let him sit with that. Let him think about that. And then see what his response would be. But that's how I kind of get these conversations started. That's how I structure them a little bit.
Have you heard of the seagull syndrome?
Mm-mm.
When you mentioned the sibling in California, I have a sibling in California.
It's a common situation.
So this happens. You get a plan, right, for Mom or Dad. Mm-hmm. The sibling in California flies in, craps all over the plan, flies out.
I have heard it.
It happens. It happens in families. It happens in my family. It happens in many families. So I just appreciate you bringing up the sibling in California.
It happens. Mm-hmm.
Okay. Good stuff. Mm-hmm. All right. What are some of the key things that families should keep in mind when introducing, the idea of hospice to their loved one?
Yeah. So I think the biggest thing, and, we've maybe touched on this before, but death is unknown. Mm-hmm. It is a huge unknown. Unknown is scary. Therefore, death is scary. Therefore, hospice, which deals so closely with death, is very scary. Mm-hmm. And so knowing that these conversations are going to be a scary thing for you to talk about or your loved ones to talk about, come to these conversations with empathy, understanding, patience, grace, allowing for, people to have an emotional response. And, a lot of times people try to avoid these conversations because they don't want to hurt someone. I don't want to make them cry, or I don't want them to get mad. I don't want to. Right. And, my thought is if you hesitate because your loved one might get emotional during a conversation about this, I think that's not a reason to avoid talking about it. I think it's a reason to talk about it. Your loved one is holding something heavy in their heart. And so you can really show up and support them by addressing this or talking about it or providing a safe space for them to discuss, what they're hoping for, what they're worried about, what they're picturing, for end of life and those kinds of things.
So these are deeply personal discussions, and the tone helps, building trust and comfort. The timing is everything, right? Mm-hmm. So what are some of the most common reactions you would say, when hospice is first mentioned that you see, and then how do you respond to those? How do you suggest we respond to those? Some of the reactions that
the reactions that people get. Yep.
Yeah.
So common reactions I get are people, I'm not ready. I'm not ready for hospice. They think that hospice is for the last day or two of life. And a big thing, I'm hoping these listeners in this podcast can take away is the earlier that you enroll with hospice, the more benefit you're going to get from hospice.
Right.
And really, if people are trying to wait, until that last day or two, think about, that's a lot of change for your family. If we're trying to get medical equipment in the home or medications in the home, or, your family, instead of being at bedside with you holding your hand, they're going to be on the phone, they're going to be signing paperwork, they're going to be, they might have to run to the pharmacy, they're going to be focused kind of on logistics. And that's a lot, to try to squeeze into the last day or two of life. And not only that, but, hospice being the gift that it is. The earlier you can give that gift to your family or to you, as a patient, the less burden your family's going to go through with those months leading up, to the final chapter of your life. So.
It isn't so traumatizing. There's time to adjust. There's time to work through all the pieces.
You get the benefit of the social worker and the chaplain. And the other thing I was going to say to this too is other reactions I get is, hospice killed my mom.
Right.
Or, people fear that hospice is going to hasten the dying process or speed things along.
Let's talk about that.
So first, it's illegal to hasten death.
Right.
So we're not doing that.
No.
We would be in jail.
Right.
But I think where this comes from is things change rapidly,
Mhm.
at the end of life. And so, patients and families can be a little bit distressed because they'll see hospice or, hospice is going to be talking to their family member about maybe taking away some medications, medications that dad's been on for 25 years. What do you mean? He's always had a blood pressure pill.
Right.
Why would we be taking this blood pressure pill away? It's going to cause him to decline, more quickly or die.
Right. Okay.
And, a lot of things like that are related to, because we're in a different place, medications that used to be beneficial can now be harmful or pose an increased risk because patients become so much more frail. So blood pressure pills, for example, if people are not eating and drinking, I mean, it's normal for their appetite to go away as they get closer to death. If blood pressure is falling, I don't want to give you a blood pressure pill.
Right.
You're going to stand up, you're going to pass out, you're going to fall, hit your head. Yeah. I don't want that. Blood sugars, people who are diabetics have been on insulin forever and ever. Again, appetite changes or, golly, if you don't want to check your blood sugar, if you don't want to poke your finger 3 times a day,
right,
you don't need to do that on hospice. What I worry about is how you're feeling.
I think when the appetite changes, I hear often from caregivers, families, they're worried that they're not eating as much and they're force feeding, and some of those things can be more uncomfortable for the patient, and they feel like that's life sustaining, and you can go a couple of days and.
Yeah. Well, I mean, and especially in American culture and probably many cultures throughout the world, I mean, food is love.
Yes.
And so what do you mean I can't?
Right.
Of course she needs to eat. Of course she's hungry. Of course she's.
Yes.
And really, truly, as the body is shutting down, it can be hard on the body to try to digest, process any kind of food that's going in. And so people who can still communicate and talk and, I'm not hungry. I don't have a taste for anything. Maybe they want a sip of their morning coffee, but that might be it. And so we just kind of tell families it's okay, it's normal, it's natural. And then I'll use phrasing like, I don't want to force feed someone. I don't want to make her stomach upset, by really insisting that she eats her oatmeal if she doesn't want to eat her oatmeal or, those kinds of things. So,
yeah. Yeah. Good stuff. We talked a little bit about this last time, where some people think hospice means giving up. And families don't want to give up. Nobody wants to give up, right? We preserve life at all cost. And then when you no longer can, hospice is the most compassionate thing you can do. And so how do we reframe that for families, the giving up?
So a simple reframe is we're not giving up, we're changing our goal.
Love it.
And so if we're, in the beginning, you're working your butt off, you're taking the chemotherapy, you're doing the surgery, you're getting radiation, working your butt off to cure this cancer. If you get to a point where curing the cancer is not on the table, then we're going to work our butts off to make sure you're as comfortable as you can be. That's so there's nothing giving up, there's nothing stopping. It's just we're changing what the focus is, changing what the goal is. And then the other thing,
what might those goals look like? So if you change from chemotherapy 3 times a week to none, what would be a new goal of the patient when we start asking what matters most today? Every day we ask that and we work to make that happen. Yeah. What kind of things would the goal be?
Sometimes it could be as simple as, I don't want to throw up today. Maybe they have a stomach cancer. They have a lot of nausea and vomiting. Maybe their goal is not to throw up. Okay, we can work on that. Right. We can focus on that. We can try. We have all different kinds of medicines at our disposal, and we'll work on not throwing up. Sometimes the goal is, I want to get outside. I think you had a patient experience where, our inpatient facility team here at the hospice house, is asking a patient what matters most to you today. And he's like, I've been in hospitals, I've been in rehabs. I haven't been able to get outside. And so to be able to wheel his bed, out into our courtyard, which all of our rooms have access to, he was able to get the sun on his face, hear the birds,
beautiful,
hear the breeze, rustling through the trees and things. And that really meant the world to him.
Good stuff. Yeah. So for the listeners, Dr. Anderson, who might be facing these conversations with their own families, what advice do you give them to help them speak with compassion and with clarity?
So what I'm going to speak to here to kind of answer this question is I'm going to walk us through nurse statements. That's a mnemonic. It comes from VitalTalk, which is where I got my training on how to have these difficult conversations. And we'll link to VitalTalk in the show notes. And then we'll have a PDF available too, to have these nurse statements kind of captured. So you can review those as well. Nurse statements are statements of empathy, and I love them. I use them all the time in hospice conversations, but also when my husband comes home from work and he's had a bad day, or when my sister's calling me and venting about, X, Y, or Z, or, you can use these anywhere. I think they're really great, especially for people who maybe they want to avoid difficult conversations because they're like, I am so awkward. I don't know what to say.
Right.
Where do I even begin? I feel like whatever I say is wrong. Or, so when you're standing in line at a funeral and you're going to go give a hug to the family, use these, when you get up there to talk with them.
Great. Okay.
So N would be naming emotion. When someone is emoting in front of you, they're crying, they're angry, whatever it is, capture that emotion in a word and say it out loud. I can see that you're frustrated. This is even customer service stuff. If you work in a customer service, I can see that you're frustrated. Wow. Sounds like you really had a draining day. You must be devastated.
Boy, it really hits people right where they are. Yeah.
And it showed it kind of is saying, I see you.
Right.
And that's what people are asking for. When they're coming at you with all this emotion, they're not mad at you, they're mad at the situation.
Right.
Or they're not frustrated with you, they're frustrated with the situation. So for you to just name it, it really helps turn that emotional volume down.
Good.
U is understanding statement. These are good for if someone is telling you this story or they're venting or this. Wow, it sounds like you've really had to jump through a lot of hurdles, or it's just summarizing, kind of for them an understanding statement, or I would imagine that must have been a really challenging decision to make. R are the respect statements. These are really great, especially if you're talking maybe to a caregiver. Your mom is so lucky to have you.
That's important. They'll remember that.
I can see how hard you've been trying to care for your mom, and I'm proud of you. These are, and patients too, man, diabetes is such a big diagnosis. It comes with so much learning, so many medication changes. I can see how hard you've been trying to manage this. Well done.
You've been really brave.
You've been really brave. Yes, those are all respect statements. Many of you listeners, maybe you've been a caregiver multiple times before, but I feel most people either never have been or this is their first time being a caregiver.
Right.
And you're just making it up.
That's it.
You're kind of just like, I don't know what I'm doing, but I'm going to try this, or I'm going to, et cetera, et cetera. And so when you're in a space where this is new and you're doing your best and you feel like you're making some stuff up, you don't know if you're doing things right, to hear anyone say, well done, good job, this is impressive, what you've been able to accomplish, really goes a long way. And even for patients, it's the first time that you're experiencing serious chronic life-limiting illness, it's a lot to manage, to think about. And again, to have someone just acknowledge that you're doing a really good job,
You can physically see people take a breath when you say that, like
definitely
exhale. Yeah.
S is support statements. I'm not going anywhere. I'm going to be here with you.
That's great.
You call me whenever you need me. Those are support statements. A patient, they're looking ahead at the future and they see this big black void, right? Of, I don't know what's going to come tomorrow. I don't know what's going to happen a month from now. Uncertainty. And so just to have a support statement, it reminds them, like, someone's squeezing my hand. Oh, I look over. Oh, my daughter is going to be here with me. Oh, my best friend.
I'm not in this alone.
Yeah, I'm not in this alone. It's still scary, but I've got somebody with me, so that it helps remind them of that. E is explore. These are good for maybe you've got that engineering family member, or friend who doesn't really express emotions. That's not, something that's a strength for them. And so explore statements would be, tell me more. What do you mean by that? What are you feeling right now? And again, you're not pulling teeth. You're not going to say, you have to tell me what you're,
right.
You're just holding space, opening that door, really intentionally saying, I'm here. I want to know, what's going on in your mind and what you're thinking about. And maybe they engage, maybe they don't, but and then it also helps you to kind of guide, oh, I thought it was fear. It's actually frustration,
right?
Or whatever it is. And so then you can empathize more, name the emotion, et cetera, et cetera. And then the other statement I want to say, as far as nurse statements or empathy statements, it's not a mnemonic, but it fits pretty much every situation. I wish it were different.
Oh, that's a good one. I wish it were different.
I wish it were different. Whatever it is, memorize that one, use that one, try that one, and just watch how people react, when you use it. And you'll really just kind of see them relax, and kind of calm down. And me too. Yeah, I do wish it were different. I wish it wasn't as hard. I wish this was an easy process. I wish, whatever it is, you can kind of put it in an I wish statement, and that's really helpful. And then my only soapbox, and this is a hot take, you don't have to agree with this or not, but I personally hate I'm sorry.
Yes. Apologizing.
You're not responsible for anything. I feel like, when someone says I'm sorry to me, especially for something that's not, they didn't cause, I kind of shut down a little bit. It's more sympathy rather than empathy. And so when I teach and educate on empathetic statements and VitalTalk and all that stuff, I really encourage people to try to avoid, and I'm sorry. But if it works for you, keep using it. But that's a soapbox of mine. So wanted to mention it.
We'll recommend I wish it were different.
I wish it were exactly. If you're going to use an I'm sorry, or you want to, try I wish it were different instead.
See how it goes. Yeah. Good stuff. Well, thank you, Dr. Anderson. I mean, this has been so rich. This was a meaningful conversation. I'm so glad we came back for a part 2. Thank you for joining us, audience, for Better Together podcast. You can find us at ourhospice.org, or you can give us a call at 812-314-8000, where we make every single moment count.